Bueno, buenas tardes. Es para mí un honor comenzar la mesa de quemado crítico con dos personalidades tan importantes que nos van a acompañar en el día de hoy, como el doctor David Greenhalgh y la doctora Medberger. En principio va a hablar el doctor Greenhalgh, que es expresidente de la Asociación Americana de Quemadura, jefe de quemadura del Hospital Shiners para niños en el norte de California, y es un profesor que conoce desde la cirugía hasta la medicina intensiva. Bueno, hoy nos va a hablar de un tema de la resucitación con fluidos en el paciente quemados. ¿Qué sabemos? Adelante, profesor.
Thank you very much for inviting me to this prestigious meeting. I'm going to talk about burn resuscitation and resuscitation in general. And I do have two disclosures. I have grants to support resuscitation trials. Here's our hospital, Shriners Hospital for Children and UC Davis, where we do our work. And the problem is that burn resuscitation is inconsistent throughout the world. And we're not sure if what we do is really adequate. I want to look at some basic concepts and then talk about burn resuscitation and what's the new theories about what to do. We all know that the body is about 60% of water in simple forms, 40% intracellular, and then the rest is extracellular, with only about 5% of our water inside our blood vessels. Water flows freely between all these compartments, but we do know that what keeps the water inside our blood vessels are the protein. We know that we compensate when we're hypovolemic with vasoconstriction, and you need to lose 40 to 30% of our volume to become hypotensive. We know that 20 milliliters per kilogram bolus will give about what you need, or about 1/3 of the 30%, 40%, in order to resuscitate somebody, and that's what we use for normal hypovolemia. But with burns, you have a massive ongoing fluid loss, so it's not as simple as that. We tend to monitor with urine output. We all know that for sure. We have other parameters, which in burns at least don't help us that much. So the classic medical school teaching is that if you lose a liter of blood or take a liter of blood out of somebody, the best thing to give back is to give 1 liter of blood. Second best is someone else's blood. And the most important part is that if you have an oncotic fluid, if you can give 1 liter back, it's because you have the protein. In theory, it stays intravascular. If you want to give a crystalloid, you got to give 3 to 4 times as much, because it leaks through that space. And so in burn resuscitation, we aren't sure whether crystalloids versus colloids are better. So for burn resuscitation, there's a lot of formulas, but we just use the formulas to start, and then we base the adjustments on what the patient does. In burn shock, we have extensive release of mediators, and you know all those, the histamine, serotonins. It's a huge increase in permeability. And the burn makes it even more difficult because albumin leaks out, and so it's outside the intravascular space. So there's a tendency to really kind of suck water outside of the blood vessels. And we know that collagen breaks down, so you have an increase in small proteins outside the blood vessels that can increase the osmotic drive outside of the blood vessels. This leak can persist for up to 48 hours and peaks at 8 hours. So it also occurs, there's a capillary leak outside where the burn is. There's a huge increase in permeability throughout the body, and we are the record holders for how much fluid you can give. I have given up to 100 liters in 24 hours, which was probably too much at the time, but typically we can give 30, 40 liters within 24 hours for a large burn in a large patient. But outside the area of the burn, the capillary leak closes relatively quickly in 6 to 12 hours, and we get profound hypoalbuminemia, so the albumin can drop to levels well below 1. And so we're not sure if you lose the osmotic pressure to keep water inside the blood vessels. And we're not sure how low it has to go, but we've certainly shown that you can go down to a level of 2 and not have problems. The other part with burn resuscitation is that the lymphatics resorb a lot of that fluid, and it can be a massive amount of resorption, and it helps us keep up with it. But with damage to the tissues, some of that is really impaired. So our problems, we have no agreed standard formula. We're not sure whether to give crystalloid versus colloid. We do have a problem with over-resuscitation. We've called that fluid creep. People tend to give too much fluid, and that can lead to more complications. And we really don't know what the proper endpoints to resuscitation should be. We know that too little fluid can result in hypovolemic death, renal failure. If you don't perfuse the skin, you have increased burn depth. We also know too much fluid tends to cause compartment syndromes, lung injury, cardiac failure, and also can increase the burn depth. So why do we have a problem? Well, the formulas are inadequate. They don't really address each patient's needs. And then a lot of times a patient can be making adequate urine, but the caregiver doesn't respond to that change. So we tend to over-resuscitate for that reason. And then we know that our oncotic pressure inside the blood vessels drops. So we tend to have persistent capillary leak. And we know that urine output is not a great indicator of outcome, but we also know that other indicators, invasive monitors, non-invasive monitors, aren't helpful either. We also know that people who have opioids, that causes vasodilation, so we tend to give more fluids. And once someone's put on a ventilator, that increases the interthoracic pressure, so you need to have a higher driving pressure, hydrostatic pressure, to get fluids back into the heart. So all those things tend to increase our fluid requirements. So we need to do better. Some responses that we've tried to do is that people in Galveston and San Antonio, Texas, have come up with a computer-based urinimeter that will actually measure urine output and adjust the fluids without relying on people to adjust them. This is called a navigator device, and it's being studied, and it may improve our outcome. People have tried to reduce the fluids required for burn resuscitation by giving very high doses of vitamin C, 66 milligrams per kilogram per hour, huge amount. And everyone has shown that can reduce the fluids. We're not sure exactly why. And one of the theories now is that it can cause an osmotic diuresis. So it's an artificial increase of urine output. And people have shown that it can cause significant hypotension, hypovolemia. And we actually showed in the study from our center that it can increase renal failure. So right now, we're not in favor of vitamin C, but it needs further study. And then we come to the debate of crystalloid versus colloid. It's been a debate that's gone on for decades. Initially, with burn resuscitation, colloids were favored. Then it was felt that colloids were not good. We should just give crystalloids. And now, currently, colloids have returned. And we need to know the answer of what's going on. It's been what I've been doing research on recently. So what are the problems with crystalloids? Well, crystalloids are freely permeable. In theory, you should have to give 3 to 4 times the amount as a colloid as you give crystalloids. And there's the question whether that has caused this fluid creep in burn resuscitation. If you look at the intravascular space, the water just kind of flows out. There's nothing to keep it inside if there's no proteins. But the good thing about crystalloids is that it works most of the time, especially in smaller burns. People can tolerate that extra fluid. They just pass it out later. It's very low risk material. It's cheaper. It's easy to store, readily available. If you're out in the field or out in the military situation, you can get it very easily. And it is established as the first line treatment. Give lactated ringers burns has been around for a long time. Colloids, the problem with colloids, they're expensive. There's some theoretic risk for infectious transfer, all that's been greatly reduced now. And the theory with burns is that the colloids leak into the interstitial space and act as osmotic sponges. So in theory, if it's leaking out, why do you give it if it's just going to pour out into the interstitial space? We do know, however, that the unburned sites, the permeability, it's high at first, but then eventually slows down and only lasts about 6 to 12 hours. And, you know, prolonged hypoalbuminemia, when you get to levels that are very low, you still have an osmotic leak in theory. The good things about colloids is that the large molecules eventually stay intravascular. That what keeps the water inside our blood vessels. It reduces the volume. And we know that the capillary leak started to close at 6 to 12 hours after a burn. So it seems like giving colloids at least partway into the resuscitation should improve your outcomes. And this just shows that these blue marks are the colloid that blocks the leak of fluid. So when it comes to burn resuscitation, first of all, I have to say that do not give hydroxyethyl starch. Great studies in sepsis, the chest studies, success, Christmas studies all show that there's increased mortality and renal failure, so do not use it for burns. Don't use gelatins, don't use dextrans. Now, people do use fresh frozen plasma. There are some formulas, the HIFA formula, the Slater formula, show that it's effective. It's more expensive than the use of the albumin, but it is a good option. And then I'll speak the rest of the time about whether you should use albumin or not for burn resuscitation. Albumin, in theory, should improve the oncotic pressure. There's some studies that suggest it may protect the endothelial glycocalyx. So I'll go over some of the studies. Well, in 1998, the Cochrane Collaborative showed that colloid albumin increased death. And so all of a sudden, albumin was felt to be an evil thing, a bad thing, you should not give it. Well, people subsequently did studies to look at what happened and given it for sepsis. And then the Cochrane Collaborative republished a study in 2012 and said, well, maybe it's not a problem that causes death. There's no increased mortality. And there's some big trials, the SAFE trial that looked in sepsis that showed that no increased risk of death. Then there was the EARS study, showed no difference. Albumin, no increase in mortality. Then there was a meta-analysis published in 2014 of those 3 studies that suggested maybe you can reduce death in sepsis with albumin. So in burns, there really are 2 approaches. You can use albumin right away as soon as they come in, or you can use albumin as a rescue, that if your crystalloid resuscitation is going too high, you add albumin. Does that reduce fluids? So I'll go over those studies. Racinos in 1975 looked at albumin immediately used and suggested there was a decrease in the amount of fluids required. Jelenko did a similar study, showed that if you get hypertonic LR in adding albumin, and when you combine those 2, the fluids were reduced, and that was suggestive of help. And then Dr. Goodwin did a study too that showed less water, but then he showed that there was increase of water in the lungs. And so it was felt that, hey, wait a minute, maybe this is a problem. He did show improved cardiac output, though, with that study. And here's the data that shows that increased lung water. So maybe it will hurt the lungs, especially when you have smoke inhalation injury. Cooper in 2006 suggested it might reduce fluids. And then we go into the studies that look at rescue of the albumin. The idea is that if you're giving too much fluid, and after about 12 hours, you're giving it, you can add albumin, it won't leak out as much, and that should improve things. So there are several studies from Utah that showed, and this one from Dr. Cochrane, showed that they looked at retrospectively the difference in those of patients who were getting way too much fluid. They added albumin later on, about 1/3 of the rate with 5% albumin. And what they found was that those who got the albumin had more severe injuries, higher lactate, more severe inhalation injury, longer time of resuscitation, and higher volumes. but no mortality difference, and suggested that it might be protective. They also, and it's from the military who were flying soldiers back from Afghanistan and Iran and Iraq, that if patients were getting more than the calculated expected 4 milliliters per kilogram percent burn, that if they added albumin, they reduced the fluids. They would also add vasopressin for hypotension. And they showed a reduction in abdominal compartment syndrome and mortality. Delahunty did the same, showed similar results. And then their studies, again, from Utah, showed that they looked at those patients that they tried to rescue when their fluids were way too high. And what they showed here is that this is the group that received albumin. Here's when they get crystallized. To give albumin, their rates dropped significantly very quickly. And if you looked at, here's the time when they started albumin, and if you give albumin, it's a precipitous drop in the fluids required. They did a similar study in children, a rapid decrease in requirements of fluid if you add albumin around 12 hours. Park did a similar study, showed similar results, and again, improved mortality, ventilator days, P to F ratio, abdominal compartment syndromes, vasopressor use. And meta-analysis that we helped publish showed no difference in mortality, compartment syndromes, respiratory complications, renal function, dysfunction. Another study by Aljayak, again, they showed improved, basically, compartment syndromes and no difference in outcomes. It was challenged by one group that suggested that you basically might have an increase. So, and I did a survey that actually looked at the difference. And what we found was that most people cheated and used albumin. So we've done a prospective trial, the abrupt trial. We actually looked at the practice throughout North America with 20 centers. And what we showed is a prospective study to look at the albumin use and basically see whether they use albumin versus crystalloid. And we had 400 patients from around North America. And what we found, this is the average types of burns. Big burns had to be at least 20%. And people started their albumin within about 3 hours, and they started pretty quickly. And it turns out that in the North America, 2/3 of people will give albumin, and those people who got it had larger burns, more full thickness burns, and higher SOFA scores. And you can see there's a huge difference in the amount of fluid that people received, but they based it on urine output. And so things that increased the use of albumin were increase in age, larger burns, higher SOFA scores. And again, at 48 hours, much more fluids. But it turned out, if you look at the standard practice, the Parkman formula is 4 milliliters per kilogram percent burn. And what we showed is that in North America, people are still using that volume, and those who received colloid are getting a lot more fluid. So we looked at that and showed that this is the colloid group. We gave albumin, it dropped precipitously like the Utah studies. And those that got albumin quicker, within 12 hours, much more fluids. Again, albumin reduced the fluid significantly, just like they showed in the Utah studies. So what we interpreted is that people, when they're giving crystalloid, if they're giving way too much fluid, that those patients were the ones that they gave albumin as a rescue. And just like they showed in Utah, that once this is the time they gave albumin, the fluid rate's going up, up. We give the albumin, it drops precipitously, just like in Utah. So we showed that those patients who got colloid were those that received a lot more fluid. And we showed actually with ventilators that those patients on ventilators required more fluid than those without. And in conclusion, we showed that the albumin group were those that had much sicker, higher mortality, ventilated, those that received fasciotomies or or required renal replacement were those groups that had the albumin group. And we showed the end of resuscitation was delayed in the albumin group. So caregivers in the United States and Canada use albumin for resuscitation 2/3 of their burn patients. Those patients tend to be older, have larger, more severe burns. Using the Parkland formula seems to still be what people do. And the albumin use is dictated by the trajectory of fluid delivered. When too much crystal is required, people give albumin with an effect. It rapidly reduces fluid requirements. This is now published in EPUB, and it should be out anytime if you'd like to see the paper. And now we have a prospective trial that's ongoing with about 15 patients comparing albumin versus those without albumin. So in conclusion, it suggests that in burns, albumin may improve outcomes. Our next study should give a better answer, and I thank you for your concern and you inviting me to this fine meeting. And I'm happy to take questions at the end of the session. Thank you very much.